Nigeria has one of the highest maternal mortality rates in the world. Currently, we are at 512 per 100,000 live births. But if we are looking at what the WHO says, it is over 900 per 100,000 live births. These are not just numbers, these are actual women dying. Why are mothers in Nigeria still dying?
You know what's killing them? For example, one of the biggest killer is postpartum hemorrhage. A woman give birth, bleed out, and that causes a lot of death. And Nigeria is actually contributing the highest number to that, which is scary. Amazing research has shown that we have solutions to all of this. When you look at the Emotive studies, for every innovation, there is always the lens of impact that it can create, but more importantly is the feasibility. Meaning, you think you can solve the problem, you can save life, but as much as you want to bring those solutions to the country, they need to work on the back of a system that works.
There are systemic challenges. It's what's the current system? What policies exist? What do we need to change at that level? How do we trickle it down? Everything from leadership, advocacy, are the finances available, to the supply chain and commodities are available. There are different layers to this. Different interventions come up, but there's no standing system that these interventions can easily flow through and can easily make the impact that it can.
Hello, everyone, and welcome to AIDS podcast series, where we tackle the toughest health challenges that affect Nigeria and the broader global public health space. We are AIDS Strategy and Consults, which is a mission-driven organization working at the intersection of strategy, of evidence, and innovation. We are deeply committed to solving complex public health problems. I'm your host. My name is Dr. Victory Ekman, and I'll be taking you through this today. I'm so glad to have you. Please don't forget to like, subscribe, comment, share as you enjoy this session. So today we're going to be talking about something very important, a very urgent question, which is why are mothers in Nigeria still dying? The title of our series today is The Silent Crisis, Maternal Mortality and the Gaps in Nigeria. And first of all, to give us a brief overview of why we're doing this in the first place, we've had decades of programs, billions of investments, and thousands of workshops that have gone on in Nigeria to solve this problem, but still, Nigeria has one of the highest maternal mortality rates in the world. Currently, we are at 512 per 100,000 live births. That is if you're looking at the National Demographic Health Survey that was done in 2018. But if we are looking at the WHO and what the WHO says, it is over 900 per 100,000 live births. So these are not just numbers, these are actual women dying, right? Actual lives being lost. And so we're going to be unpacking these systemic gaps today. And I have two amazing colleagues that will be taking us through this today. I'll be discussing with. First of all, on my right, I have my own boss. He is the CEO at AIDS Strategy and Consult, Mr. Afiz Olajire. Thank you very much for being here.
Yeah, thank you.
So Afiz is a visionary health systems reform specialist. He has done a lot of work in this space. He is known for his catalytic thinking. He loves to disrupt things. He has worked across multiple programs over the last 15 years, and especially in the maternal and child health space. And here I have Toluwanimi Adewale, the ever pragmatic Nimi, always with the fire, you know. She's one of our senior engagement managers, and she has over 7 years of experience in the public health space as well. She currently manages our maternal and child health portfolio and has successfully implemented multiple projects to solve this same problem. Afiz and Tolu, thank you very much for having us, for coming here today. We're so glad to have you.
Yeah, thank you, Victory.
Yeah.
It's a pleasure to be here to discuss this very timely topic.
I mean, thank you so much for that wonderful introduction. But yeah, when you said it, I couldn't believe that I've already spent 7 years in this space working. So
believe it. Please like, comment, subscribe, and we want to hear from you as well as we go through this session. So let's get right into it, right?
Yeah.
First of all, as we've already explained, Nigeria, women are dying while giving birth, while doing something as natural as giving birth. And we've been trying to solve this problem for at least 4 or 5 decades, right? So the first question I'm going to be asking, which is to you, Afiz, is why? Why do you think we are still having this problem? Why does this struggle continue despite decades of program policies aimed at reducing maternal deaths?
Yeah, thanks, Victory. And I think it's a very timely conversation. Timely because it's at a point where both globally, everyone see the need to halt the rate at which our women are dying. And even in Nigeria, where we stand, we are lucky to be working in an era of very seasoned and intentional leaders, from the Honorable Coordinating Minister of Health through a lot of initiatives like the MAMI, through the SWAP agenda, and how everyone is just using a concerted effort to bring everything together. And from the recent declaration by the Gates Foundation as well, I think it's good to know that maternal and newborn health is a priority for everyone. So yes, we want to stop the woman from dying. But it's not as straightforward as it is, especially in a country like Nigeria. And from all of the work we do and the experience in the past years, it's clear. I think the first thing about the Nigeria system is we have had some years where we have deficit in the investment in infrastructure. So when the team of research and development team worked collaboratively to even understand what's killing the women, we know what's killing them. For example, one of the biggest killer is postpartum hemorrhage. A woman gives birth, bleed out, and that causes a lot of death. And Nigeria is actually contributing the highest number to that, which is scary. Yeah. And amazing researches has shown that we have solution to all of this. And that's when you look at the Emotive studies that pioneers such as Professor Adiza Galadanchi through the Emotive studies have done. So now, how do we bring that home to Nigeria? Few things. For every innovation, there is always the lens of impact that it can create, but more importantly is the feasibility. Meaning, you think you can solve the problem, you can save life, but as much as you want to bring those solutions to the country, they need to work on the back of a system that works. Let me give an example. If you need to stop women from dying and you need to administer a particular injection, as an example, you need nurses and midwives to give that injection. You're not going to allow the security or the technician at the gates of the hospital to give injection. Yeah. So that then brings us to the problem of health workforce that is suboptimal. We have suboptimal health workforce, and the ones that are even there are trained by the curriculum that were designed decades ago. So there is that problem of, even though we know if we do this, we'll stop the women from bleeding to death, but there is the big gap of where are the people that will actually administer this intervention, those health facilities where we need to implement all of these things, how equipped are they, what's the level of revitalization that has happened to them in the last few years. So that gap between the impact we can create and how feasible it is for us to actually deploy all of those things still continue to stand between what we can achieve and why we still look like we are back. So I think that's a first attempt to it.
Okay, so from what you've said, I'm seeing that like it's more of a systemic problem. It's not just a maternal health problem.
Absolutely.
So maybe like Nimi, what do you think?
So for me, I think the major issue would be there are different interventions. There are different things that can lead to what we are looking for, what we hope for, which is women not dying, right? The problem is different interventions, different people implementing, and then no system or structure to sort of push that continuously for the longest, right? And just like Afiz had mentioned, there are systemic challenges. It's what's the current system? If I'm bringing an intervention, like he had mentioned what Professor Galadanchi had already pioneered, right, in terms of the Emotive bundle, and then realizing that this was done, of course, small scale to understand the intervention, to see the success that it comes with and the impact. Now think about it in terms of scale up, right? What is required? So you have to think through it in terms of what policies exist. That's your already thinking system, right? What policies exist? What do we need to change at that level? How do we trickle it down? That now goes into the infrastructure. That now goes into the the healthcare workers that is required. That goes into even the state leadership. So you're not just thinking everything from leadership, advocacy, of course, at that point, are the finances available, to the supply chain, the commodities are available. There are different layers to this, right? And what we now see is different interventions come up, but there's no standing system that these interventions can easily flow through and can easily make the impact that it can make. So for me, which is why we always talk about health system strengthening. The problem I feel is that we haven't gotten it right. We haven't gotten health system strengthening right. Those are the same issues we meet whenever you are trying to roll out an intervention. Is you meet the same problems, the same issues, you are trying to just build the structure. I mean, in terms of routinization that I had implemented in the past, that's one of the key things that we're trying to do. But you realize that once somebody is done trying to push that agenda, they pull out, that system fails. So what we should really be thinking about is that how do we ensure that a system remains, and the word is, how does it stand the test of time? How does it stand the test of people, right? How does a system actually stay and then birth results? Because that's really the conversation we should be having. Those are my thoughts.
Yeah, so I think I completely agree with that. We are having, one thing I've really brought up from the talk is that there is fragmentation, there's this, there's that. Many people are bringing interventions, innovations. Maybe after this, you could just give us a little bit about like the emotive that you're talking about, in case our viewers don't know much about it, right? But then what we're talking about is that there's fragmentation, and it is about consolidating everything. So these billions of investment, it is not being brought together as a system. When one person finishes, they go, another person comes, probably with a similar thing, but it is not being systemized, if that is a term, you know. So maybe what is the emotive we keep talking about, just so that our listeners will not be lost?
Okay, so I think I'll start first from what it's trying to solve. So just like Afiz had mentioned, PPH is postpartum hemorrhage, which is really bleeding during labor, right, or after labor, right? And we realized that that's one of the major causes of maternal mortality. So Professor Galadanchi with her team were able to come up with a structure called the Emotive, so where you are able to administer a lot of interventions at the same time. So now when I say a lot, I don't mean you do a lot of things, right? But I will start with the process. So it's a woman is at labor, she's bleeding. They realized that, okay, how do we measure this? One of the key things they realized when they did the study was, we don't have a proper way to measure the amount of blood lost, which helps you to even know, okay, is this woman at severe
at
blood
what
loss?
point?
At what point, right?
Should we intervene?
And so the first thing is the drips that she brought about, which is using those drips, putting it on the bed. The woman is there, the blood goes into the drips. You're able to measure, it's calibrated. So you're able to measure and say, okay, this is the amount of blood that has been lost. Then you know, okay, we need to administer. So what are we administering? So before, what typically happen is they'll first of all maybe push IV fluids, maybe push oxytocin, one after the other. But what she's saying is push everything together. Push everything at once, massage the uterine, and then let's see what happens. And from the research that has been done, it has yielded lots of results. So that's really what the Emotive bundle, that's why they call it the bundle treatment. Right?
Okay.
And should that not work, the E in that last exercise to escalate. Let's quickly escalate, because then you've already applied exactly all of the things that needs to be done. You need to escalate immediately. Right. I mean, what we can definitely would also like to hear from everybody's thoughts on even just understanding how that structure works. Have they experienced it? Maybe if healthcare workers are listening to this, or even mothers, have you experienced this even at the public health facility? But that's something that's currently being scaled up in Nigeria, and it's a surefire way to actually reduce PPH. That's severe PPH, which is postpartum hemorrhage. So that's all about the Emotive, essentially. Okay,
thank you, Nimi. I had wanted like just a brief overview of that so that people are not lost. But that's just one example of an intervention that is ongoing, right? And we're having so many of this. So, Afiz, I'm going to ask you again, similar to what we've said before, but if you want to look at what area of the health system, whether it's policy, whether it's at the community level, in fact, is the biggest challenge. I know it is going to be a difficult question to answer, because you will see if you want to look at each of them, they are big. But which one do you think is the biggest challenge looking through the health system down to the community level? What area do we have the biggest challenge?
Yeah, thanks, Victor. And I think Nimi had made a very excellent point around the systems company. But just as you said when you were introducing me, I like to disrupt conventional thinking.
Yes.
So for me, I think the biggest problem we have is that people have lost confidence in our healthcare system.
Trust.
So the trust is already lacking. And that already called for us to then use the money we should be investing in delivering care into even convincing people. That's what we call advocacy and demand generation. We have to invest a lot to even convince people on the need for them to go and deliver in the health facility for them to save their life. So that's one problem. So for me, and that's why I like what the current administration is saying, which is let's go back to the basics. Let's even revitalize and ensure that when people finally get to the health facility, they have quality healthcare worker, equipped facility that convince them and give them reason to want to come back. Because in the past is we do a lot of advocacy, get people to the health facility. Then when they get there, what you then realize is the quality of care you get is lacking, and naturally nobody wants to go back again. I think that's the first thing.
Yes.
The second thing is also we will not shy away from the cultural barriers, unchallenged norms that is really hindering the outcome. Everyone still feel or fulfill culture that why should a woman have to get to the hospital before they deliver? In fact, I've had some conversations in the past when I realized that it has a ranking. More like you're in a classroom and the first position is the person that delivered herself. The second position is the one that is delivered by either the co-wife or somebody within the house. Then the third position is that you then use a traditional birth attendant. Then the fourth one is you go to the hospital and you are delivered within a few minutes of being there. Whereby definition of you failing in a classroom is
CS.
They have to do cesarean section, right? So all of those stigmas sometimes make people to rather prefer to die in the house than go into the health facility. So I think there is that. But the second bit of it now is also the human resource, which I think is a big problem.
Okay.
Is in a country that has our kind of population, we should be doing a lot to retain our best brain. But we know the idea about the Jackba syndrome.
Yes.
Good that there are not a lot of attention to bringing people back home. But we need to create an enabling environment for them to want to come back. Well, there are three categories of problem about human resource for health. There are people that Jackba, that's what we speak about. But the one we are not speaking about are the ones that are here. How many want to even go to the rural area where the deaths are happening most?
Exactly.
Everybody wants to work in the metropolis. Some of us, when we are having our NYSC, definition of you being a big boy or big girl is that you served in Lagos or you served in Abuja or you served in Port Harcourt. Something as small as that. When they post you to go and impact life at scale in a school, you probably use some extra effort to get yourself to serve in a place where your genius is not as required as it is. So as much as the world is paying attention to the Jackpa syndrome, I think we also need to come back home and actually look at even the ones we have here, how many want to serve within the most vulnerable population where these deaths happen. So I think those are some of the additional systemic problems. We can't unpack it in a day. There is the funding
Definitely.
gap. There is the when we need to think about commodity and everything, someone needs to pay for them. USAID funding cut has taught us that nobody's coming to rescue us. We probably need to rescue ourselves.
Yes,
and for
definitely.
me, that's then where we need to make every kobo count. That's always my own slogan. Every single kobo should start counting for results. And yeah, I think that's where I will want to pause that so I don't drag this further. So I think they wanted to say something.
I want to say something to that, right? You had made like very key points around just the way you divided, or should I say structured, people that are living and those that are even here that don't want to go there. And I just said, let me just put myself in their shoes for a minute, just from their POV. The problem is their safety. Is it sure? Is it guaranteed there? Right? Their career projection really stem from there.
Exactly.
There are a few things. So the because I of course I used to be of that school of thought, and I still am that. The reason why we are having these issues, the reason why you will go to a facility and you not see any doctors or midwives is appalling to me, right? And you see that they even came up with this new structure where it's even the board that's what's the word? I think there was a time where you tried to the word has skipped my head, but in trying to just where the NYC gives allocates people exactly to go and to go to these states. Also the same thing even for what you call their housemanship or something like that. Okay, so they even for your housemanship, you are also pushed to go to a particular
they do that
state.
now.
That was one of the things they tried to do to also ensure that there are many
they are covering a
wider range. But then what you now see is that even if they post somebody to a particular place, they are looking for how to work that, just like he said. And it's because if they go there, there are many things that even a parent will be thinking about their child going there. Right? So which brings me down to the system. Do you understand what I'm trying to say? If it's not working, nobody's going to feel comfortable enough to go there.
Yeah.
right? Nobody's going to feel, even if you think about the early days of immunization, the amount of work that needed to be done to even get to those rural places, right? And thankfully, it's opening up. We're having people that we are training that are indigenous and able to, administer as well. But if you think about it like that, is the issues are, it's across different sectors.
Yeah.
We need to, just like you said, like make every couple count, but then think about it not just from the lens of just healthcare alone. Think about it from the economic lens. Think about it from the different,
so a whole systems
education,
approach.
because just like you said, right, is are they even from the health worker? Let me go back to your thoughts around health workers being equipped from the training points, the schools. Let's use for midwifery, right? At that point, like, are we ensuring that all the different key players are part of the process end to end, and they can see how they fit into the bigger vision? Because for me, that's where it is. If for instance I can't even think about it right now. But if every minister is thinking about how a youth moves from, whether it's education, whether it's how the economy is going, because even the economy will not allow you to want your child to go there. They're not going to pay them as much. You understand? So you are thinking as a person, as a youth, or as, let me say, as a doctor that I'm learning. I'm thinking less about impact. I'm thinking more about how do I make money?
My children?
How do I feed my children?
My kids to school.
Absolutely.
So you see how it cuts across. So the question now is, what do we do? Right, and it looks so big right now, but it's taking it piece by piece.
Absolutely.
Right, taking it bit by bit and saying, okay, let's work on this system.
Absolutely.
Let's get this system right.
Absolutely.
So that, I mean, those are just my thoughts. Just to go back to Emotive, I wanted to be sure that I captured it even for the readers, because Emotive is a slogan that has a meaning.
Yes.
Right, and E is early detection, M is massaging the uterus, O is oxytocin,
Yes.
T is tranexamic acid, IV is IV fluids,
Yes.
right?
Okay.
And then E is escalate. Yeah, so just wanted to be sure that I captured that for the audience.
Yes, I captured it very well. And as we discuss system issue, just where she landed about escalation, that's another topic I would want us to dive into.
True.
Because when I then need to escalate, what's the referral system? Where am I referring?
How
to?
are they getting
and
there?
How are they getting there? Our emergency transport service is still not at its best. Yes, this administration is doing a lot to fix that.
Yeah.
But if as a medical officer that you probably not be incentivized right, I've gone to good hospitals, I've assessed care in hospitals where when they immediately refer you, somebody's already calling that old hospital. They are waiting for you at the emergency to receive the word, right? But what's the reality at the grassroots where these deaths are happening? So for me, we also need to then fix that as part of the system problem that we are looking to fix. Like if I need to escalate, what are the existing structure to escalate when there are problems, right? And how do we ensure that we have a system in place that gets people, that prioritize every life as a jewel? So sometimes when we talk about those numbers, just from your introduction, we need to know that it's people dying. It's some people's only hope going, it's future being destroyed. Because a child that is being delivered and the mother died, if that child survives, we already know that child already starts lacking some essential care from birth. And that oftentimes shape the outcome of such child, right? So if we start treating every number with that kind of rigor and honesty, I think everyone will wake up and attack this issue more. Yeah.
So, sorry, Dixie, to just add, right? Just as you were speaking, something came to my mind is it possible, just thinking off my head, to map out the different pieces that is required, and then everyone sees themselves in that piece and begins to work on each part of the system? And so if, for instance, say Nimi now is working on referral system and ensuring that system is strong, right? And then Anafiz is working on HRH and ensuring that system is strong. A Victory is working on this part of the system and ensuring that so if we are, will it be easier if we target certain things either simultaneously or one at a time to ensure that everything is working? Would that make a difference? That's one. Yeah. So
you are going to talk about the what we should do very shortly, but I just want to ask from the audience, this is a very layered issue, right? So let us know what you think is the biggest barrier, or are the biggest barriers, because as you've seen, nobody can mention one thing. Nobody can mention even two things, right? So what do you think are the biggest barriers that are hindering us, like, from doing something about our maternal death? maybe I didn't mention in the beginning, we, Nigeria, are responsible for 28% of the world's maternal deaths. Do you know what that means? Every 1 in 4 women that dies during childbirth or during the maternity process in the entire world is in this small country. Okay, maybe large country, but you get what I mean, right? So it is crazy. So what do you think are these barriers? And just to summarize what my colleagues have said, from what I've heard, right, there are 2 major issues I've gotten out. First, a health systems issue. We've talked about from the community level, we've talked about from demand generation from the community level up until policy, governance, everything we've talked about can fit in there. And then, as Nimi very aptly pointed out, a whole systems level, a whole systems problem. So not just the health system in this case. We're now looking at the education system, the economics, we're looking at agriculture, we're looking at finance, right? So even if we are able to solve only the health systems problem, right, we still have the entire Nigeria to contend with that fits into that.
Absolutely.
Yeah.
So it is very layered. It's what we call a wicked problem.
Yeah.
And so that would now take me to Afiz. Many countries have solved this problem.
Yeah.
Nimi started talking about the solution, so I want to come back to her after.
Okay.
But many countries have solved this problem.
Yeah.
There are countries that don't have any deaths, any maternal deaths per year.
Yes.
There are countries in Africa that have less than 100 maternal deaths per year.
Yes.
We are the giants of Africa. Is it too hard? What can we do to solve this problem?
Yeah, I don't think it's too hard, frankly. And I think we are almost there. And this part of what inspired the ACE brain for us to start a company called ACE. I'm sure Nemi was part of it at that inception phase where we are bouncing idea, which is really having worked across countries and states. It's then a point, at least there was a point that I was working across 8 countries, 5 countries in Southeast Asia, 3 countries in East Africa, and 1 country is in West Africa or Nigeria. And I think one thing that is clear that I've seen is we all know the answer, we know the right word to say, but people are not intentional about contextualizing the solution. So more of, and just like Nimi has said, Nimi has defined what emotive is. Emotive has been done in even other countries. We know it's working, right?
Okay.
But we've agreed the motive is working. What nobody has agreed on is for a country like Rwanda that is keeping their birth rate and mortality low, one thing that is synonymous to that is out-of-pocket expenditure is not a lot. So we need to bring it on. There's a very interesting work we did at some point in this, because just as you said, we try to disrupt conventional thinking. And I think that example gives us an idea of how we can use homemade solution to solve problem.
Okay.
I think it was an issue of family planning. And the real concern is family planning uptake is very poor. And family planning uptake being very poor then taught us that how can we fix it? The first thing we realized that the biggest problem was spousal disapproval. Spousal disapproval, husband are not allowing their wife to take family planning. So what did we do in a very brief time? Is we engage the community and we see that where can you get the largest population of those husbands in the place, and realize that in that culture, there are settings of where that happen. People go to tea vendors to have tea. So we engage the tea vendors, we train them on family planning, we gave them some capital to expand their business, and we told them the only thing we want is educate people about family planning. Such that when a man comes back from work in the evening in his relaxed mood to take some tea, someone is telling him about family planning. And because of that, when you get home and your wife is telling you the need to plan the child to reduce her chances of dying during child delivery, the message is not too strange to the husband because she just finished hearing it in the company of her friend. And if you get angry and you be like, I'll not go to this tea vendor again, I'll go to the next one. That next one is part of the people we've trained to teach you about the same thing. And from there, family planning uptake in that particular state started surging because people now have the right message and the spouses are no longer the barrier between the uptake and the attitude. Do you understand now? So that's why we can use local solution to fix our problem. And it's adaptive learning. We train health workers, for example. Now we are in the era we want to get people to eliminate postpartum hemorrhage and all. But Nimi mentioned drape, which is meant to measure the blood. But a drape will not work well if it's not on the ideal hospital bed, that has that hole in
Positioned
between, that
properly.
position properly, that allows it. But we need to face the reality that in Nigeria, right, most of deliveries still happen on the mat. Some hospitals don't even have the hospital bed. So how do you use the drape? So maybe it's time for us to start thinking that even if you want to use the so-called drape, how do we ensure our training is tailored to our reality? Because nobody is going to equip all of the health facilities in Nigeria with the right hospital bed. So if you want to deliver on a bench, for example, can we find a way that you can still measure those blood if you need your hand to scoop it in? So I'm not using a slide I developed in Geneva
to
fix
come
and
problem.
train somebody that is working in my locality, right? So, and for me, I think that's how we can solve it. And as we do all of that, one thing is very, very certain. We know a few things. One, poverty index has direct implication to maternal mortality. So we need to reduce out-of-pocket expenditure. I've worked in an hospital before at the emergency where they rushed the patient in. As we were trying to take the patient in, the family were collecting the patient back. And the only one of them was saying is that he's dead already, don't take him. If he goes in,
We'll spend
the money we'll spend to get him back. And we were actually telling them that this person is still alive. But the head of the family kept telling them, please, don't allow them to collect this person from you, because the money you will pay to get this patient back. But imagine a world where you don't need to think of the cost, and the only thing you need to care about is getting quality health care, right?
Yes.
So we need to be intentional about removing the barrier. Yeah, there are a lot of interesting work. When we started the Emotive work 2 years ago, Nimi, I think one of the problems is that tranexamic acid, which is one of the strongest components to halt the bleeding during postpartum hemorrhage care, is not part of the essential care list of what the health insurance cover. We're glad we are with a lot of advocacy and all that has been fixed, which is what I admire about the current government. They are actually going back to the basics to say, let's fix it. So meaning the commodity like oxytocin, like tranexamic acid, like drape and all of that we need to arrest these deaths. Can we even have them as part of what is covered in your basic health care? Then as we do that, encouraging people to take health care automatically guarantees them that my delivery is likely to be safe.
Yeah.
So, and that's what I think we need to do to solve the problem in Nigeria. We need to tailor our solution. We need to contextualize the approach. And we need to be certain that this solution that we are designing it with the community, not for the community. What currently happens is that we design a lot of solutions for the community. We design it for the state. Then when we get there, we realize, because what happened in Ebonyi will not work. What work in Ebonyi might not work in Kano.
True.
What work in Abuja will not work in Lagos sometimes. So we need to be intentional a lot of the time. So we need to be sure that we are co-creating solution, and that's why what we stand for as an organization, which is we want to disrupt conventional thinking. Because if the conventional thought is working, why are we still in this mess? So for us, we disrupt the conventional thought, we contextualize the solution, and we ensure that we are co-creating with the team and not for the team.
Yeah, thank you very much, Afiz. Please don't forget to like, share, comment. Let us know your thoughts on everything that has been said. From what Afiz has said, it is solvable, right? Our problems are solvable, but we need to go back to the drawing board and start the solution from a bottom-up approach rather than a top-down approach, right? I'm going to go to Nimi now because you were talking about there's something you were saying that was very interesting, which is why I wanted you to wait. How we should be able to fragment the problem, and then people should see where they can fit in and to solve the problem. Yeah. So could you share more light on that?
Yes, I will speak from where he stopped at some point when he mentioned the poverty index, people being even able to afford care, right? And then people even saying that, I mean, I've been in communities where I'm advocating for them to do a particular intervention or to take a particular vaccine, and they are saying, oh, for government to be pushing it, this is why government has not solved the poverty issue. Do you understand? They have not solved a lot of issues, so why are they pushing for this, right? Of course, I mean, that's not the correct way to think. If I step back into their shoes for a moment, right, I can understand. Which is why I said there are different sectors that need to be working in order for other sectors to work as well. So the health sector is trying their best to ensure that these things are available. But then other sectors are not doing, maybe trying, but at least are not doing according to the people, are not doing its best to ensure that they are also, good. And that brings me to the sector you mentioned, agriculture. What are we doing there? What are we trying to do to also build the will I say, not the wealth, but the standard of living I mean, we can already see what has happened in terms of the amount of inflation that has happened just in Nigeria in how
True.
many years, right? And then someone is thinking, I still need to afford care. I still need to be able to access care, right? So again, we need to, like, that going back to the drawing board is not going back to doing the same thing that we've done before.
Yeah.
Because anytime we talk about these things and somebody picks this now, they're thinking, how do you make impact? They'll go to a small community, administer the mom, and they will leave. No. Is, like he said, co-designing, co-creating from the bottom up, contextualizing, and not saying it's not fit for all.
Yes.
That's the truth. It's not fit for all, right? And then it's, do we need to sit down?
Yeah.
All the different ministries, all different sectors. Do we need to sit down and say, these are the issues at this point. This is how it will feed into all of this.
Absolutely.
Right? And then say, okay, let's pick this one by one. Let's pick this here. Let's pick this here. Let's pick the biggest issues and solve them. Right? At least funding is not the issue for now.
Yeah.
Do you understand what I'm saying? What we need to be thinking about is what targeted funding, targeted solutions.
Yeah.
Because once it's targeted, then you're sort of assured that, okay, when I leave, this has been done. It's less about the individual. It's less, as in I'm talking about the office and the sector, but more about the office and the system that have been put in place.
Yeah.
Is that system standing? Backing things by legislation, backing things by law. Do you understand that?
Yeah.
When someone even gets into that office, it's like, this is how it is. To change it, we require this. Do you understand? So it's like, it's a system. So when I'm saying system, don't think, leadership, supply chain, this is, for instance, if the supply chain system that remains, so that when another person comes and is heading that team, they're not saying, what do I want to just change? Is there things that are already laid and it's like, okay, this is working. Of course, you can tweak things based on what would be better if you have you have a good idea. But the point is, there are some structures that need to be standing. I'll give you an example of, let's say, just even use ACE as an organization. No matter the manager that comes in, there's a structure in place. We have PS every Friday.
Yes.
No matter you can't just come in and say you want to change it. For you to change it, you have to have a conversation. There needs to be discussions. You need to let us know why you're changing it. Yeah. Is it going to work in the long run?
Yeah.
Do you understand? There's already a structure, there's an onboarding structure. If you want to change it, you're going to have to go through some level of some levels to change that. You get? Yeah. So the problem is, we don't have structures that are standing. But the way I even think about it is they are very deep in the ground. That are standing. That's
a good foundation.
And the foundation, exactly. Yeah. We don't have that. When somebody comes, no idea.
And I completely agree
or we
with
move.
You. I worked in a state in Nigeria in 2022. We're doing immunization survey. And my biggest finding that really moved me was that the LGA with the highest card retention rates, card retention means you have vaccinated your child, but you still kept the card, is the LGA that was flooded. They were displaced. And I asked that.
Why?
And they said because our immunization card is what we need to assess relief every time there is a social investment support. So, and that is to buttress Nimi's point about we cannot just keep going to people to say, take this, without building their trust in the system. So, I can't be hungry and you are telling me to come and take vaccine. I will ask some questions, right? So, same as we want people to go to health facility to go and deliver and all of that. But this woman, probably, why are we looking at things from addressing her bleeding too much and not already solving her anemia, which is caused by malnutrition and a lot of other problems. So, like Nimi had said, it's like a big puzzle. Ministry of Women Affairs, because education of the women has direct relationship with the
exactly.
Yes.
Ministry of Women Affairs, education, economic, finance, everyone needs to see themselves.
Everybody has a part to play.
But if we are looking at solving maternal and newborn health from just health perspective, we will never get there. There is the Ministry of Transportation who need to get mothers, women to where they are supposed to be.
Yes.
So all of these things, we need to start seeing it as, for me, I see it as, we should be seeing this as an emergency. The way we were treating COVID, where there is a COVID situation room, that there is 20 cases, we need to address it.
Yes.
Until we come back and we are looking at it that one woman died here.
It is appalling.
We need to know why she died and why nobody will have to die from such a thing. I think until we see it as a systemic problem, we'll never get it.
You know what I was thinking? I was like, what if we pick a community and just we pick all the different sectors and we solve all the problems there piece by piece, and then see how that community will thrive.
Yeah.
You in the agriculture, you're giving them seeds, you're giving them, you understand, you're teaching them about how they can, grow things. You're teaching, they are going to, okay, you what animals there, how do you're building businesses, there's insurance. Like, I'm just thinking about starting small, and I'm just on top of my head, of course. Like, I mean, just thinking about it from that lens and then piecing all of that together, because we all need to sit in the same room and agree on what we need to do and then do it.
Absolutely.
That's what I think. So that we're not just all conversations.
Exactly.
If we want to talk about this thing, I think we may have to talk about this in another episode, because this is something that we can dissect. I think we can dissect it so much further, right? We've talked about so many things. We've talked about, first of all, I'm going to try to break it down. There is, from the community level, or from the demand side, I would say demand supply. The supply side, I would say the health system and the system as a whole. The demand side is trust. You mentioned trust, right? Yeah. You mentioned trust, not just in the sense of, the people trust that when they get to the health facilities, they're going to get the care that they need, but trust in the sense of, does the system care about me? I don't have food to eat. I don't have money to pay for, and then you are saying I should go deliver at the hospital, that the health worker is going to probably say, come and pay this 500 naira for this. I would rather keep that 500 naira in my house, right?
Or use it to feed.
Or use it to feed, use it to do something. So there is trust from that level. And there are so many things, our norms that stops people from actually accessing care. And there's also a lot of other things that we can dissect actually from the community level. But then you now come into the health systems level, where most of the problem lies, the systems level, not just health system. We have established that. So you now come into the health system, right? Which is the entire thing: workforce, infrastructure, governance, financing, and the rest of it. And then the entire system, which you've rightly said, every ministry, everybody can fit into the puzzle. They have to identify, where do I fit in and how can I help? And another thing that has come out from this is we should take this as an emergency. I think there was a year I learned that a mother died in I've forgotten which country exactly, either Switzerland or Sweden, I'm not very sure. But everybody sat down together to say, what's happened? Why? As a country, Nigeria should get to that point where it makes no sense that somebody is doing something as natural as giving birth, something that has been done since the beginning of time, and then they are dying, right? Yes. So this is something that we must solve. And I'm going to ask, like, our audience, what do you think can solve this problem? How can we solve this? We don't presume to have all the answers. Nope. We love to gather information. We love to get information to use to solve this problem, but we are very passionate about solving this problem. ACE is trying to do a lot with regards to maternal and child health in the area of digital health, creating strategies, infrastructure, family planning, and the rest of it. We are doing a lot, and we could talk about that in the future. But we want to hear from you. How do you think this problem can be solved? Right? There is no idea that is too small or too crazy. We want to know, right? And I want to say thank you so much to Afiz and Nimi for making this session. I can see your passion. I can see your drive. I can see that this is really a problem for you, something that we want to solve. And I'm very, very glad that you guys are here to talk about this today. And so, to our audience, thank you so much for joining us. Thank you so much for listening. And stay tuned for the rest of the episodes. We are definitely going to be bringing this up again and dissecting this some more. So, thank you so much for joining us. Again, this is ACE podcast series, and we're very glad to have you. My name is Dr. Victory, and thank you.
Yeah,
bye.
Thanks, Victory.
Thank you.